afternoon everyone, I'm Julie. I'm the Children's Orthopaedic Pain Nurse Specialist at Maidstone and Tunbridge Wells. I was the first one of me that came into post, so it's been quite an exciting role to create, create my role and improve the service for the children that we care for. We have 4 now paediatric orthopaedic surgeons in Maidstone and Tunbridge Wells, and we're doing quite complex surgery. So yeah, I kind of hit the ground running. COVID came along quite soon after I started, but we haven't let that stop us. We're still running. So I've presented this study day a few times. I hope it's of use for you. I kept it simple, which I felt might be a good starting block. And in time, if you want more different things, then I'm really happy to share. So next slide, please. So introduction into children's pain. I usually like doing these things face to face. It's really hard on the screen, but I like to put it out to everyone and say, how do you define pain? And everybody gives me their own ideas, and that's great, because what pain is subjective to each individual. It's not a set rule. We have we all have our own experiences, and likewise so do the children that we care for. We're going to think about pain assessment, pain tools and how to use them. I have touched on non-pharmacologically, but I will leave mostly that as to our lovely play therapist specialist. Now you've got me at it, who is coming after me. But I use non-pharmacological methods every day. They're fantastic. I won't go into too much depth about our acute pain guideline that I've written for the trust, but we will be thinking about pain scores and linking them with medicine and what we do in our trust when we need help. Next slide, please. So what is pain? Next slide, please. So pain has been defined as an unpleasant sensory and emotional experience caused by actual or potential tissue damage, or described in terms of such damage. The inability to communicate verbally should not negate the possibility of needing appropriate pain management. Pain is subjective experience, and a person's report of pain should be accepted as that and respected. I'm sure you all heard that many times over, and that's your official definition. Next slide. So there are 2 types of pain. Well, there's more than 2, but I'm just going to think about these 2. We've got acute pain, which is what we're talking about really today. Now, acute pain is usually associated with a trauma or an injury. So we've got our patients that come to A&E with a fractured arm or fractured femur, etc. Or you've also got your children that have had operations, they've had surgical pain. We may have had procedural pain, and most common procedural pain would be taking bloods. But pain has got some positives as well. It assists to wound repair, and it serves as a protective function. So if you fell over and broke your ankle, for example, the pain would stop you walking on it and making that ankle fracture worse. It also alerts you if you've got terrible stomach pain. It alerts, I need to get looked at here. I can't just carry on with my normal things. It kind of stops you in your tracks, so that we make sure we deal with the problem. So that's acute pain. I'm going to talk a little bit about chronic pain. So chronic pain generally is something that happens if the acute pain hasn't been dealt with initially. It's a pain that persists beyond the normal pain healing time. So that's pain that exceeds 3 to 6 months or beyond. This is to serve a protective function anymore, and it can be associated with considerable suffering. And then there's also neuropathic pain, which we won't be going on into detail about today, but it's useful to know that it's out there. Next slide, please. So the continuum of pain. You'll never guess how long it took me to make this slide with all these little pictures, but I did it. Very proud. We're not technical computer experts, us nurses, are we? So the continuum of pain, we start off with an insult, an acute pain. So like we said, it could be a fracture, could be a blood test, could be surgery. And at that point, we're serving that protective function. But after the 3 to 6 months, we go into the chronic pain. and that can degrade health and function. And I'm sure some of you have come across that in work and through family members perhaps. Next slide, please. So how do we manage children's pain? So we've got the most obvious, we give them some Calpol or some ibuprofen, or we might think about more things like gas and air. But as our lovely play specialist in a little while is going to talk about, there are so many non-pharmacological methods which we use every day in managing children's pain, such as play, distraction, guided imagery, the use of ice packs, heat packs, immobilizing in splints or in traction, positioning with pillows, surgery, massage, the list goes on and on. Next slide. So pain assessment tools. I know we've all seen many different pain assessment tools, but most trusts have a certain few that have been verified and we're allowed to use. So I'll be showing you ours in a moment. Pain assessment tools ideally are chosen by the child. They're individual to the patient and they need to be validated and appropriate to the developmental age. And there needs to be training to all healthcare professionals who are using these tools so that they are used effectively. Child and family are involved. So, for example, when I pre-assess patients for surgery, I show them our pain assessment tools at that point in pre-assessment and get them to choose which one they like, teach them how to use it. And then when they come to having their surgery, they're already a bit clued up on what's going to happen and reassured that we're going to deal with their pain early on at the bottom end of the pain scale. Next slide, please. So here we go. Which one are you going to use? So these tools are all out there. There are others. There's the revised FLAC for children with special needs as well, which we use in our department. But I've just chosen these three to put on the slide. So the Wong and Baker, which is my favourite with the faces, this one's suitable for children over about 4, maybe 3, up to about 7, but there's no reason why older children can't use the Whaley and Wong faces. Lots of people generally go in and ask their patients, oh, what's your pain score on 0 to 10? And some children just can't manage to think it out the top of their head, which is why it's good to show them the actual line, the actual numerical line, so they can think, actually, let's think about it. Where am I on this pain scale? I don't know whether any of you have had experience with children when you ask them their pain score and they come out with, oh, it's a 16 out of 10. And it's because they don't understand. I mean, my 15-year-old daughter, that's who said that. And she didn't get it. She knew that she was in the worst pain she's ever experienced. So it's got to be more than 10. So it's about educating that worst pain is 10. And anything below that would be further down. So I love these pain tools. We laminated them, we've put them in little booklets. We use them every day at work for our patients. Some nurses pull them up on their phone. They're really easy to have to hand for patients. And then you've got FLAC on the right hand side, which is your nice simple one for younger children. Next slide, please. So I think I've gone through them all singularly here, so you can have a look at FLAC there, suitable from 2 months to 7 years. And then your revised FLAC is suitable for any age, and you can make it appropriate for your child. So you can put tips, things in there that child does when they're in pain by using mum to help you write that. Next slide, please. Now you've got your faces. And the next slide. You've got your numerical rating scale or flat or VAS. Okay. So when do I take a pain score? This is a little quiz and anyone's welcome to shout out which ones they think it is. It's difficult when we're doing this virtually. So we go to the next slide and it will tell us the answer. All of the above except for B. So pain scores should be documented with every set of observations, which is at least every 4 hours. Ideally, we should be doing it a lot more often than that. We do pain scores all the time without realising it, but we're very bad at writing it down. So I'm working really hard with our nurses to encourage them to document when they've done their pain scores. It's always important to do a pain score before giving analgesia and an hour post giving the analgesia as well. Next slide. So what medications are we using? Next slide. So we use a multimodal analgesia route. So we like to cover all bases. We start with paracetamol and anti-inflammatories such as ibuprofen, and then we bring in our opioids. Oromorph is our favourite of choice, and then any adjunct, I can't ever say that word, adjunct drugs such as diazepam for muscle spasms, and so on. Next slide, please. So I've created this little chart. I've since updated it. This is my first version. It looks a bit more professional on my recent one, which I haven't managed to pop into this yet. But this basically says the same thing. So here we are. We have your paracetamol plus your non-steroidals, opioids, and local anaesthetics. So our trust, we use a lot of local anaesthetics. We do lots of caudal blocks, femoral nerve catheters. We don't use epidurals at the moment, so femoral nerve catheters are a godsend. And all of these methods are used when in operating theatre. And these are the doses that I am aiming to get them using. So for post-operative pain, we can give a maximum dose of paracetamol up to 75 milligrams per kilo per day, and then divide that in your to your 4 doses. Obviously, no more than your 4 grams a day. Ibuprofen, we can give 10 milligrams per kilo per dose 3 times a day, or diclofenac if you're giving it, if you need to give it PR, is what they use. And then we've got Oromorph at the doses of 200 mics to 300 mics every 4. Well, if they're giving the lower dose, we're starting to give it more like 2 hourly, and it makes a real difference with the child's pain. So what I've discovered is if we give those maximum doses of paracetamol and ibuprofen, we're using less morphine and opioids, which of course reduces all those side effects of constipation, nausea, itching, etc. And then of course you've got your IV route down the bottom. And not to forget your diazepam for spasms, particularly with our fractures femurs and our hip surgery. These children really benefit from diazepam as an antispasmodic. Next slide, please. So how do they work? Right, well, I don't know whether you want me to go into too much detail about how these drugs work, so please stop me if I go over doing it. Paracetamol is a non-opioid analgesic. It's used for mild pain. Families are very happy using paracetamol, and children usually quite like the taste. It doesn't have any anti-inflammatory action, but it is opioid sparing, so if we use it at the right doses, it does reduce the amount of morphine that we need to give. It also helps by bringing down temperatures, and as we know, it's metabolized in the liver. So it's thought that it inhibits the prostaglandin synthesis in the brain, although it's not completely proven how it works, but it does. So we like it. And it's well tolerated by the stomach, so it's a real good first choice pain relief. Next slide. Your non-steroidal anti-inflammatories. So main ones we use in paediatrics is your ibuprofen and diclofenac. The side effects, which really bothers the doctors, they don't use it much in adults anymore, anti-inflammatories, so I'm having a bit of a battle to remind them to please still prescribe it for children, because with adults they won't give it if they're nil by mouth, they won't give it without omeprazole, and they're very conscious of the gastric erosion and renal impairment and things that it can cause. But in children it's really, really safe, and we still use it, and it's brilliant stuff. So when we get our new run of doctors in, it's back to the drawing board, doing this teaching again to remind them that please give it to the children. But our paediatric doctors are great, so if they haven't been prescribed correctly by the orthopods, I just trot along to the peds and they will add it onto the drug chart for us. So next slide, please. So there's lots of weak opioids. We are not using opioids other than Oromorph in paediatrics now. We don't use codeine at Maidstone and Tunbridge Wells, and we don't use tramadol or buprenorphine. These are still used in adults, but they are trying to move away from them because codeine, for example, works by turning itself into, the body turns it into morphine, and not everyone can metabolize codeine. Some people metabolize it really well and have a very, good effect from the codeine. Others, all it does is make them constipated. So we try not to give that to children, and definitely not under 12, 14, and we go straight to morphine. Next slide, please. Here we are. So we mainly give it as the immediate release morphine, which is your Oromorph. We do have the slow release morphine, and sometimes they try that with the children who have more pain, more chronic pain, or more long-term pain, like the sickle cell children, as we're not using morphine infusions other than a PCA, which is just a bolus only, which is a bit of a difficult one. But we are we're sticking to the liquid Oromorph. And oxycodone is there for children that cannot tolerate morphine. But please remember, if you're using morphine for your patients, don't forget the laxatives. We mostly put them on Movicol, and always have antiemetics and naloxone prescribed on the chart. Next slide, please. I've just seen Laura's note, but it's gone. Tell us out loud, Laura.
I was just just your point about non-steroidals. They're very much used sparingly in critical care in children that are, I've noticed, that are very unwell because of the risk of renal impairment. But yeah, I was saying it's, backing up what you're saying, it's a very good drug, and the healthy child with an acute pain because of an elective surgery or a trauma, yeah, it's very effective.
Yeah, and I think that's the problem, isn't it? Because the doctors are aware of if the child has got, other problems, if they've got renal problems and things. We don't want to obviously make that worse. So I think there's kind of cutting back on it, but remembering, like, as somebody else has said, it's a great antipyretic. Absolutely it is. And so in paediatrics, in our healthy well children, we use ibuprofen, and we just need to remind our doctors that it's safe and to use it, because it makes a huge difference. And these children, their length of stay is really cut down. I'm getting children home the next day that were staying 2 or 3 nights because we're giving them the right pain relief and sending them home with some Oromorph. It makes such a change, and they're much better off in their own homes.
Yeah, you're getting them up quicker, I would imagine. That's good.
Yeah, I mean, yesterday, for example, we had a little girl had a varus osteotomy, so femoral osteotomy. She's 10, for previous DDH, and she was up and doing the stairs post-op. I mean, she had a really good block, and she couldn't quite feel her leg, but she was so comfortable with the paracetamol, ibuprofen, and a really good block. She was up doing the stairs, and I was like, I'd rather you stay tonight because the block will wear off and the morphine's not come up from pharmacy yet. And if you don't stay tonight, when that wears off, you're going to be really sad. But it's hard to explain that to a child who thinks, well, I'm up, I'm okay, I'm off. So yeah, we do have an issue with getting the TTOs up quick enough to get them out with their Oromorph the same day. But in instances where they've had really big surgery, 1 night in hospital is wise, just to be sure that they're not in too much discomfort when that block wears off. So there's a slide up there about Oromorph. It just and IV morphine just reminds us that morphine is our gold standard because it doesn't have to metabolize into morphine, and we can give it IV, we can give it orally. In Maidstone and Tunbridge Wells, it's only given IV by the medical team, so the registrar or above has to give that IV morphine. We do have use a PCA, but it's at the moment we're using it as an only bolus only, so I'm working hard to try and get that as a background infusion, but it's going to take me a bit of time, but I'm going to get there. We also use intranasal diamorphine in I need to be careful using paracetamol. Oh no, missed that. I'll go back to that in a sec. Intranasal diamorphine is used in the A&E department, which I've done some teaching on in A&E, and we've got a guideline that I've taken from the Royal College of Anaesthetics, which is in our acute pain guidelines. So the nurses now have a proper written guideline, unlike a picture on their phone that they were sharing between them, which wasn't great. So we're getting there. So we're getting there slowly. Next slide, please. So effects of opioids, I think we've kind of gone through that already. So I won't harp on. Next slide, please. So here's our WHO pain ladder that you may well have all seen before. Originally written for increasing cancer pain, where we start with the the paracetamol and your anti-inflammatories, and then gradually going up the ladder to using our opioid drugs. But with post-operative pain and trauma, I like to turn that round the other way, so that we start, you thinking you've got a child in severe pain, we need to get that Oromorph or intranasal diamorphine in straight away, maybe even using gas and air as a stopgap, and then we get the anti-inflammatory and the paracetamol in as well, so that we can spare the amount of opioids used. But it's important to think we don't just take it step by step and see if it's working. With acute traumatic pain, we need to get on top of that quickly. Next slide, please. Oh, next slide, please. Thank you. So I'm not going to go too deeply into this. This is something out of our acute pain guideline, but they show you, what to do in different areas. You assess your pain on triage. You've then got your choice of pain score. You've then got what drugs you give for which pains, and so on. So these are in our acute pain guideline, and I just pop them in these slides just to show that our team, that they're there, and if they're not sure what to do, they can find these in our guideline. Next slide, please. And this has come from the acute Royal College of Emergency Medicine, and it's just a bit more colourful and not as wordy as my slide that was written before I came. And next slide, please. So we won't do the scenario because I know I'm talking too much, but this is what I do with my team when I'm doing some training. I get them to have a think about how old are children, what pain tool would you use, what medicine would you prescribe, work out doses. Has it been given regularly? Is it written on the regular side of the drug chart, which is a bugbear of mine, and so on. So next slide, please. So non-pharmacological, I'm just going to lead slowly in for our lovely play specialist next. Non-pharmacological methods. Next slide. Fear and anxiety can really exacerbate pain. So children's fear before a procedure can heighten their perception of pain. And negative distorted memories of painful experience have been linked to greater distress during subsequent procedures. So children that have had a really bad experience, for example, having a blood test that really hurt them, next time they have to come in for a blood test, they're going to be a lot more frightened, and it could be much more painful for them. So it's really, really important that we're in this position where we've got children experiencing their first experience of pain, that if we can make that as positive as we can, in the future, we're not going to have children who are adults that are frightened of coming into hospital. How many people do you know that are terrified to go to the dentist, or frightened to go to the doctors, or into hospital? So what I'm hoping, in the future, will improve the management of pain in children, so that when they're young adults, they won't be frightened and avoiding medical care. Some of our children that have had frightening experiences with the plaster saw, just the sound of the plaster saw can cause them distress. So it's about introducing them to that sound and making that less traumatic. We've been talking about things like VR headsets in plaster rooms, phlebotomy, to help with our distraction of our children. So that's something we're thinking about getting funded by the services that do fundraising. I can't think who they're called. Like the League of Friends. Next slide, please. So these are us. This is me. If I'm not on duty, because I am only me, we have the acute adult pain team, and obviously always the anaesthetist on call if you've got a child in severe pain and you need some assistance. And don't forget the play specialist team and parents and carers who know their children the best. They are fabulous support to managing our children in pain. And I think I've done it, half an hour. Phew. So I'm passing back.
So Izabela, I'll hand over to you. Thank you so much for coming to talk today.
Hello. So my slide is very short. I have read a really good paper that was written in Sweden, and this is where the first reference comes from. But anyway, reading about, I was actually wondering, should I bring any papers into this talk at all? But I think what's already been said, it's enough. Maybe if we can move on to another page. By the way, the picture that you can see is from play sessions I did with diabetic patients. We invited, it was before COVID, so we were able to invite siblings to hospital as well. We're working with diabetic patients and their siblings and talking about injecting insulin and doing other painful things that were to do with their treatment. In the picture you can see, this is one of the examples of desensitizing that can be done. So we made different creatures out of little oranges and stickers. And we decided that they're all different because we're all different. But in the end, they all needed to have some insulin injections, and they were all having a really good time about it. And it became something of a normal thing for the siblings and the patients to do insulin injections. So this is one of the things that we can use as play specialists for our pediatric patients. This is called normalizing play. So you will be able to see maybe on the next slide. So this is the quote from the paper I was talking about, and you can see more of the orange creatures that we made that day with the diabetic patients and their siblings. I do apologize about my voice. I hope it will last till the end. And on the next slide, I'm really sorry. This is what Judy was saying, that pain is very subjective. So depending on the patient, it can be something to do, for example, with their sensory perception. It could be something that maybe we need to work on their understanding. So this is where the cognitive aspect comes. So how you could use a play specialist or a play specialist team. I put the components on one of the sides, and on the other, on the next slide, you will be able to see some of the practices we can provide. When it comes to the cognitive component, I think that understanding is absolutely crucial. And this is what Laura has been working on, this the preoperative play, anything to do with surgery. And when children come to have a procedure under general anesthetic, we have found out in our hospital as well that if the family has a good understanding what's about to happen, it immensely helps their perception of the procedure, and it really helps to calm them down. There definitely is pain-related anxiety in our patients, so we've been trying to work around our patients to provide as good support as possible. So we have created a video. We try to play with the medical equipment prior to the general anesthetic. We do things like painting with cannulas. We allow a lot of water squirting through cannulas using syringes just before we have a surgery. I think 2 weeks ago, I had a patient that was enjoying playing with cars, and I thought, actually, the mask that we use for gas induction could be pumped up. So we have spent about 5 minutes pumping up the mask because it's like pumping tires on a car. Oh, that helped a lot with the gas induction that was about to happen soon after. Because children like to play, so this is what they normally do. And if we allow for this to happen, it definitely helps later on with the procedure. It could be, it definitely is not just about general anesthetic. It could be anything. We can do normalizing play and play around the treatment it could be the lumbar puncture. A lot can be done about blood tests, definitely cannulations. If you would like to, I can show you one of my blood teddies. I have got here in my bag with me. It has got a saline bag inside. It's properly cannulated, has got a red ink inside, so you can properly draw some blood from a cannula and you can give it medication. So because it has got a port here, it pretends to be a Hickman line, or it could be like accessing a port. And I've made quite a few of them for our patients. They have taken them home. These teddies live in their houses, and it definitely helps with normalizing the pain. It definitely helps them to lower their anxiety around the treatment they are receiving. This is where the sensory component of the pain, the perception of pain comes. And we have been using a lot of different resources. For example, we've been using PECs. I think Julie talked about this when talking about scoring pain. Sometimes patients are just not able to verbalize it. And sometimes we've been using PECs to help them with that. A lot of these resources are available for free. So we've been using PECs to help patients understand the procedure as well, and it definitely helps. Very often these patients will come with a lot of their resources already. Parents are very often very well prepared anyway, but it's good for us as a team to have something in place. So we've got a massive box that the play team have put together, and we like to have this feeling that it's there in the box. If we need it, we can pull it out and we can use it. Apart from that, we of course have got sensory equipment like bubble tubes. We've been really lucky because Starlight has given us the mobile unit recently. So not only in the sensory room, but also maybe by their bedside, we have been able to use sensory equipment to calm them down, and it definitely helps with the pain-related anxiety. Oh, I'm really sorry. I'm in somebody's office and the phone is ringing. And also the sensitizing, that definitely comes under the sensory component of the pain. So like I said, playing with the cannulas, playing with medical equipment, that definitely comes under the umbrella of sensory component. When it comes to behavioral component, I was actually thinking about it, and I thought that where plating comes is the role modeling, because we very often can afford to spend maybe a bit more time with the individual patient, and like Julie said, pain is very subjective, so getting to know the individual patient definitely helps you to think what would be the right approach or the right resource. So I hope you would be able to use your play specialist, your play team, to spend a little bit of time, especially if it's a long-term patient, to maybe prepare something for the patient that would work long-term, like the blood teddy. It could be something to do with the wound care. It may be that they need dressing changes. There can be quite a few resources created, and I only work in a general hospital. So there are so many play specialists that have fantastic experience working in very specific areas, and they just have got such fantastic resources that I probably don't even know about, and they are definitely the gems. So the role modeling, for example, what I've noticed, the blood teddies that I have been making, I also made a dolly for one of our patients that struggled with dressing changes. And when we introduced the doll to our patient, she immediately named it. It was Baby Rosa. And the patient immediately took the role of a nurse, was talking to the baby as to a patient. and basically told the baby not to worry because the nurse is going to be gentle and that the baby only needed to stay still. And the role modeling was just something that the patient just took. I think also because there was this trusting relationship built. We have played before. We had the time to meet. We had the time to build a relationship. And I think that's why we knew the patient would like the dolly. So it worked. And then the affective component of the pain that I just wanted to mention is the feelings and the attitudes. Like I said, the girl trusted us and she liked working with us before. So I think as soon as you can establish this positive relationship, it definitely helps. Because in the end, we want our patients to build this resilience. And as much as it's sad for us to see, but we want them to get on with it without needing us. And I think when a play team will say, oh, look, they're just doing it now. They're getting on with another blood test or another dressing change or another access. It's great. And this is where we step away. We come back from time to time to say hello, and we will be there to give them their favorite sticker, and we will be there with a treasure chest because we know what they like. But we are very happy to step away after time. I've been working since October with a patient under 10. It's a girl, and she needed to have blood tests, and she really struggled. We've had some play sessions, and she would come to hospital just to play with me. And this was the whole process of desensitizing. And I think on the third or fourth occasion, she came to her blood test smiling. She just sat down, literally did this, the phlebotomy team. And I thought, oh, she does not need me anymore. It was great. So if you have play specialists, this is what you can use them for. Oh, I haven't mentioned distraction at all, haven't I? Of course, distraction during any sort of treatment. This is what plating does. And if we're talking about distraction, what I wanted to say, we are trying to have it as interactive as possible. So not just to have a tablet to watch, but have something that we can interact with the patient during the procedure. Because if you're interacting with the patient, you know exactly you can also see what the team is doing behind, so you know where to give your attention really high, and then maybe when you can lower the level of the interaction a little bit to give them that moment to breathe. Playing just looking at a tablet, even if it's like a game for them to play, will not do it. But honestly, this is where we come.
There's a question as well about your teddies in there as well. So you might, if you've made them yourself, you might have to do a tutorial on how to make the teddies and the dolls.
Let me take it out of the bag so I can show you.
Yeah, that'd be great to see.
So it's one of them. So it's here. There is a saline bag, and oh, you can't see it. Let me lift it up. So it has got a T-shirt. So it's nice if it can have a T-shirt. And here it's just a cannula. So saline bag has been cannulated, and there is ink inside. But I wouldn't give a patient a bag with ink. Then I tell parents, you know, it's up to you. It can just be the tap water that I've put in, or if you're brave enough, have some food coloring. And as you can see, it is definitely working. So there's blood coming out. So it's really good if it's a patient that has got access all the time. It could be chemo going in, any sort of medication. So it's really versatile. And if it's a patient that comes for a blood test, I sometimes use just the saline bag filled with water and red ink, and basically you can just put the butterfly, the needle, in it and show them how it works. And you know, if you're brave enough, if you know your patient well enough, allow them to handle some of it. But this is it. When you get to know them, you know how you do your own risk assessment, and then you need to decide if this is the patient to do with it, or maybe they just need to watch it from a distance.
That's brilliant. Thank you so much, Izabela.